Okay, so I'll go ahead and start us off. So it's my pleasure to introduce Dr. Rick Wallace, who's the Associate Director of our College of Medicine Library. He has quite a pedigree, including his Master of Public Health and Doctorate of Education from East Tennessee University, his Master's of Applied Organizational Management from Tusculum College, his Master's of Library Sciences from UT Knoxville, and his Master's of Divinity from Mid-America Baptist Theological Seminary. And he's talking to us today about critical appraisals. So I'll turn it over to Dr. Wallace. Thank you for doing this for us.
Thank you, Preston. I really enjoy, like I said, working with the department. This is on critical appraisal. I call it critical appraisal for the average person because that can be intimidating. So neither I nor any members of my immediate family have a financial interest, arrangement, or affiliation that could be perceived as a real or apparent conflict of interest related to the content or supporters of this activity. So you've probably never seen a disclosure like this. I'm talking about critical appraisal, but yet I'm not that great at critical appraisal. But I must say that it gives everybody a hard time. It's a lifelong process. I do have an MPH in biostatistics and epidemiology, but it's still scary and intimidating, and no one wants to admit I am not that great at critical appraisal. But yet it's not that hard, and that's okay. Archie Cochrane is the guy that they named the Cochrane Database of Systematic Reviews after. He's a British physician, and I read an autobiography of him recently, and he said matching on the basis of human judgment is open to error and the distortions of bias. But by introducing the random allocation of subjects to groups, the randomized controlled trial transcended such human fallibility and set controlled trials on firmer foundations. He realized that just human judgment alone failed to come to the truth needed to practice medicine. He said it was hard time that medicine monitored and accounted for how they were serving the public. Too much that was being done in the name of healthcare lacked scientific validation. That was his constant thing. There seems far too little interest in improving and promoting what was effective. Now, we've seen a recent change over that recently in the last 10 or 15 years, and hopefully that will continue. Cochrane said, this is undoubtedly the point at which the immense potential of the randomized controlled trial began to dawn on me. It offered clinical medicine and health services generally an experimental approach to questions of effectiveness and efficiency and a massive step forward from validation by clinical opinion and essentially subjective observations. So he really warred against subjective observation when there was no clinical validation of how medicine was being practiced in the UK. He was a British doctor. And then along with that, I read this book not too long ago. It was by Michael Lewis. You may have heard of him. He wrote the sports books, The Moneyball and Blindside. I think both of those were made into movies. He's basically a financial guy and writes on Wall Street. But he wrote a book called The Undoing Project, A Friendship That Changed Our Minds. And it's by the Israeli psychologists Daniel Kahneman and Amos Tversky. Tversky is dead. I think Kahneman's still alive. He won a Nobel Prize after Tversky died. But their whole field was how we make decisions. And they basically said, we have two minds. One is a rational mind and one is a intuitive mind. We think that we use the rational mind all the time, but yet we're not. And he said this shows up in various places. And they went around doing these little tests on groups of people, documenting these little quirks that our minds have to deceive us in certain ways. And they called those heuristics, was the name they came up. They were two characters, to say the least, if you ever read the book. But they were in Toronto for a while, which was the place where the foundation for evidence-based medicine was. And they interacted with some of those folks there in evidence-based medicine. So a movement was taking place in Toronto that came to be called evidence-based medicine. The core idea of evidence-based medicine was to test the intuition of medical experts to check the thinking of doctors against hard data. When subjected to scientific investigation, some of what passed for medical wisdom turned out to be shockingly wrong-headed. So Redelmeyer was a doctor who worked in this huge hospital in Toronto, right next to a very, very, very busy interstate highway where there are a lot of wrecks and there's a lot of ER patients that were constantly coming in the hospital. And he spent time with Tversky and Kahneman on separate occasions, and he realized that doctors make these same kind of heuristic mistakes as the rest of us do. And so he was hired just to go from clinician to clinician and help them with their reasoning. That was his job. I don't know if he's still alive and he still does this or what. In Redelmeyer's experience, doctors did not think statistically, which is a lot of what understanding the literature is. 80% of doctors don't think probabilities apply to their patients, he said, just like 95% of married couples don't believe the 50% divorce rate applies to them. So these two books sort of came together for me. Tversky said that relating to airlines, that what Delta Airlines should do was to change its decision-making environments. The mental mistakes that lead pilots of planes bound from Miami to boneheadedly land in Fort Lauderdale were woven in human nature. People had trouble seeing when their minds were misleading them. On the other hand, they could sometimes see when other people's minds were misleading them. But the cockpit culture of a commercial airliner did not encourage people to point out the mental errors of the man in charge. And this has been true in medicine as well, such as in surgery, where the chief surgeon is not going to listen to anybody else. And that they tried in the last 10 or 15 years to radically change that. But this is a problem in all professions. So out of Toronto came evidence-based medicine. And you could say that evidence-based medicine is doing research, finding the results, doing critical appraisal of it, trying to understand its reliability and validity, taking out the useful evidence, using your professional expertise, and applying it to the patient with the patient's values and needs. Of course, you do that in the context of the resources that are available, and that's where libraries come in. Another way to look at it is assessing the patient, asking a question, acquiring the literature, then appraising the literature, and then applying it to your patient with your wisdom and their values. Or you could just condense evidence-based medicine down to evidence, patient values, resources available, and physician expertise. So I really like this slide right here. There's a group of people out of the University of Virginia called the Info Mastery Group. And they came up with these two concepts, DOEs and POEMs. So DOEs are disease-oriented evidence and POEMs are patient-oriented evidence. And to make it come out, I guess, to rhyme, they said patient-oriented evidence that matters. It matters to the patient, it matters to the physician, and so on. And they say that disease-oriented evidence is not particularly helpful to the clinician, and yet most of the literature in the journals is disease-oriented evidence. So this is part of a chain that's eventually going to hopefully lead to a patient-oriented discovery. And they back that up by showing these examples where there's just too many times where in the past, the clinical people started using the disease-oriented evidence before there was any patient-oriented evidence and actually produced harms in human populations. For example, doxazosin for blood pressure, the human reasoning was that reducing blood pressure would be a good thing, and yet they found out it increased mortality in African Americans. Arrhythmias following acute MIs, they thought it just made brain sense to suppress the arrhythmias. They found out that increased mortality. Sudden infant death syndrome, vitamin E, histamine antagonists like PPIs, a hormone replacement therapy, beta blockers for heart failure. They thought that would reduce cardiac output, which was bad. And now they realize that it reduces mortality in moderate to severe disease. Beta blockers are used all the time. One thing that out of trying to organize the evidence that has been derived, that's very helpful. And I'm trying to show you things that not only that you need to do, but things that are being done by other people to make your job easier, to sort of the cliff notes of medicine. They've already done the appraisal for us, and we welcome that. But One new thing is the attachment of levels of evidence and strength of recommendations, usually levels of evidence. And this is a level of evidence chart from Oxford, I think, where you have systematic reviews as one, various shades of systematic reviews. Then you have cohort studies as two, and case control studies as three, and so on. So that's a level of evidence table. And this is a strength of recommendation table based on a group called SORT. So when you're looking up evidence, you should look to see if indeed there are levels of evidence listed or strengths of recommendation. And in any new database that claims to be evidence-based, if it doesn't list these, it's not really truly evidence-based. Dynamed, for example, does a really good job. I'm not sure if UpToDate does a good job of listing levels of evidence, strengths of recommendation, and so on. And there's different groups that do these. So here's just a straight ABC strength of recommendation. Excuse me, and they have levels of evidence too. Usually levels of evidence are more for individual articles, and strength of recommendations or for recommendations of practice. So like here, recommendation A is based on consistent and good quality patient-oriented evidence. A B is recommendation based on inconsistent or limited quality patient. And then if you look for an individual article, level 1 for a treatment article would be an RCT, basically. So sinuses. So these are people doing the work of, excuse me, doing the work of critical appraisal for you, and you ought to take full advantage of that. That's really what we need. So here's another one that's maybe even more famous than SORT. GRADE stands for Grading of Recommendations, Assessments, Development, and Evaluation. So you can see how you can get for a certain activity in medicine, a high grade, a moderate grade, a low grade, or very low grade. I can go a lot more into this. I have several other slides on grade, on how specifically they do this, but I don't have those listed here. So a lot of the backbone of improvement in clinical medicine is from RCTs, because they're experimental type studies and you can control for bias, which is the bugaboo that we don't think we have, but we do. So a lot of what RCTs is, it's just hypothesis testing. So you have a null hypothesis and a research hypothesis, and then you have a focused question, hopefully in the form of a PICO question. One important thing that you consider when you do an RCT is the power of the study. Basically, it's the N, or the size of the population. And how big that needs to be can be influenced by several variables. For example, the p-value set. A lot of these drug trials are set at 0.0001. So if you have a p-value that's stringent, you need to have a huge N to find an effect. And that's what you're doing when you're calculating power. You don't know which way you may find an effect, but you know if you have a certain power that you should be able to find an effect. You want an accurate measure if possible, because if it's an inaccurate measure, again, your N has to be huge. Variability of results. You can have a smaller sample size, a smaller N, if all the results are the same. If everybody comes out positive, there's not a great need to have a larger sample size unless it's too small. But the rule of thumb, and there's a way to calculate power, is 80%. So you should look for that in studies that you read that are like RCTs. I mentioned earlier, you cannot do good research unless you have a focus question. And one of the best ways to do that is PICO, patient population problem, intervention, control, or outcome. This is also good in the clinic when a resident is trying to describe their problem and they're having trouble focusing in on it. A lot of times they'll try to ask 3 questions in one. This will help them focus their question asking, and that means they can do better retrieval of the literature once they form their question. So like here's a PICO I made up. P would be adults with depression. I would be a new drug treatment. C would be the standard treatment. And O would be reduction in depression. And several things you're looking at when you're looking at a randomized controlled trial. You're looking at the magnitude of effect. A lot of times that's measured by a statistical tool, a lot of times by relative risk. And so usually you have 1 as a cutoff, and then anything between 0 and 1 means the null hypothesis is superior. And then if it's over 1, that means the research hypothesis is superior. And how far over 1 will tell you how strongly that is. So there's a difference between a relative risk of 1.5 and one of 7. The direction of effect, so does it support the null or research? The precision of effect. So they use in research confidence intervals to show that. So they don't give a point of where the effect is, they'll give a range. And you always look to see if the range crosses the line of 1, if it's a odds ratio or risk ratio. And then the chance of random effect would be the p-value. Some considerations about looking at randomized controlled trials or doing randomized controlled trials. You can have the right outcome, or you can make 2 possible errors. One is to incorrectly reject the null, which is considered a type 1 error. And 2 would be to incorrectly accept the null. Excuse me, the first would be a type 1 error, and incorrectly accept the null, which would be a type 2 error. There's a long history of randomized controlled trials in medicine, going back to scurvy and lemons. So James Lancaster was an English sailor, and he came up with the idea his men were getting sick with scurvy. And I don't know if he observationally observed them eating citrus fruits and doing better, but he started implementing that on his ships, which he was captain of, and he had great success. But it wasn't really looked at again until 1749, almost 150 years later, by James Lind, and he set up what we would consider a crude randomized controlled trial where different sailors got, some got lemons, and they later changed it to limes. That's why British sailors became called limeys. But Lind found a big difference in people even that were already sick once they started eating the lemons. But it wasn't adapted widely until 1795 by the British Navy, in 1865 by the British Merchant Marines. So they knew this information in 1601, but it wasn't widely adapted until 1865. So our discoveries may not be that bad as far as the time lapse to get into practice, but we still have a problem today. Feinberg found that only 2 of 28 landmark trials, such as thrombolytic therapy for myocardial infarction, fancy way to say aspirin in the ER for heart attack, that only 22 of 28 landmark trials were implemented within 2 years following their publication. This means that new discoveries in medicine are not being quickly translated into better treatment for patients. So that's another reason that we need, to teach critical appraisal skills and information management, is because of this gap. A lot of things that scare people are statistics. I'm not a great statistical person. Unless you do this all the time, you're not going to be that good. But, I can figure out in most research articles what the purpose of the statistical measure is. Usually it's a variant of some base class of statistical measure. But these statistics right here all fit together. Odds ratio, which most often is used in cohort studies, risk ratio used for RCTs, relative risk reduction, absolute risk reduction, and then number needed to treat, which is 1 over the absolute risk. So in my little thing that I came up with, in our trial drug, we'll say that 52 had reduced depression, 63 no reduction. In the standard drug, the comparator 46 had reduced, 74 had none. And from just that table right there, you can calculate all this: the odds ratio, the risk ratio, the relative risk, the absolute risk, the number needed to treat. So the odds ratio is always going to be higher than the risk ratio. And of course, the relative risk will be higher than the absolute risk. And that can be a real problem in kind of deceiving people. And I'll show you that later. Number needed to treat is a good statistic because it's people friendly, it's patient friendly. So they may not understand statistical numbers, but when you tell them 1 out of every 9 people who derive this treatment are going to derive a benefit. So that's what you're dealing with. Or 1 out of every 27 derive a harm. That makes it clear to them. The NNR is kind of a joke. I read this article in the Journal of Internal Medicine once, and they pushed literature out to the wards in a hospital, Cook County Hospital, to experienced physicians. And then they went back and measured, based on the literature, if they changed the treatment, if they changed the diagnosis, if they changed advice. And they did in every sixth patient, which I think is pretty impactful. So they made up a number needed to read. So for every sixth article a physician read, the patients derived a benefit from that. And that's pretty powerful. Just more on statistics. Again, you don't need to know how to calculate linear regression with a pencil to be good at using your own literature. Nowhere even close. I certainly can't do that. But a lot of statistical measures fall into just measuring differences. And a lot of times they do that by measuring averages, and they call those means. And so measuring the average differences and seeing if there's a statistical difference is just a t-test. And there's other tests like that. And a lot of the test that they'll use depends on what category of data that you have. So nominals like yes or no, black and white, ordinals like a Likert scale, interval and ratio have true spaces between the numbers. And like, this is just a regression line here. So all these dots are answers to questions or biological characteristics or whatever. And this tells us if there's a relationship between them. And not only can you do that in regression, but you can use it to predict. So if I tweak this one here, how does it affect this one up here and so on? So really statistical measures are kind of cool. You can measure RCTs by differences or by ratios. And I might add that the hazard ratio is in that family of odds ratios and risk ratios. And we usually think of a hazard ratio as like used in a cancer study. Where everybody's going to die in 5 months, but one group lives 2 months longer. I mentioned earlier using absolute risk versus relative risk. Need to be careful with that. So a drug reduces the risk of cancer from 1 in 5,000 to 1 in 10,000. Well, that's still not much of a reduction at all. I mean, they were at 1 in 5,000 to start with. So the relative risk for that is 50%, 0.5. But the absolute risk is 0.0001, which looks like what, 1/100th of 1%? Am I looking at that right? So you need to be careful. You can, researchers can intentionally try to fool you. Consort, something you need to know about. It's a group in the UK. And this is a flow chart for designing a randomized control trial that you'll see maybe in a paper that Consort has that people use. But it's also good to use to examine RCTs that you're looking at as a map to know what the researchers should have included in their trial. And they also have a checklist version of it as well. So that's got that page and that page there. And then I want you to know about Prospero. I think it's cool. It's a website at the University of York, and it's more for the systematic review world. But when you do a systematic review, you really should write a protocol, which is kind of your roadmap ahead. And Prospero is a registry for people's systematic reviews. And you can go in and see what other people have done, and you can register your trial. And you can find out if somebody's already started on your idea 6 months ahead of you, and there's no use for you to really go down that path. So notice at the bottom at the Prospero, when you fill out your protocol, and this is free, it's open to the public. They have participants, population, then interventions, and then at the top of this page, they have comparator, control, and then main outcomes. So they have the PICO concept embedded in here. So again, although I'm mainly mentioning RCTs, another thing about systematic reviews, I just like forest plots. I just think they're cool. I think they're graphically artistic, and I think they illustrate so many statistical measures. So you can see the line of one, they're using an odds ratio in this case, and it's about a assertive community treatment, and to see how that affects the rate of hospitalization. It looks like in that Bond versus Indiana and Test versus Wisconsin, they've had some success. The line doesn't cross one. The diamond is the size of the N of the population. Usually the bigger the N, the more narrow the confidence interval. You can see those other studies touch the line of 1, other than the pooled odds ratio, which was, I guess, a statistical measure they do to combine all the results. But it just illustrates things so clearly, and you see these often, and they're so easy to gain information from by a quick glance. So critical appraisal does not help the availability of evidence. That's up to your profession to create new evidence. And I'm sure that goes on all the time. It doesn't help with the accessibility of evidence. Some of that in your current situation depends on us in the library, what we can afford to subscribe to. And that's can be a problem once you get out into private practice. How do you stay in touch with the evidence? My first position was to go around to rural hospitals, kind of knock on the door and say, hey, does your medical staff need any information, any journal articles, any searching, any whatever from us? We'll do that for you. But it does help with the quality of evidence. And there's so much evidence anymore. And there's so much that, we know now that we can't just at face value accept. We have to have some critical appraisal chops that we can go and evaluate that. And that's actually a good thing. It makes life easier because it tells us a lot of stuff that we don't need to read, because we want to read the top of the heap, the best evidence. This is a good way to do critical appraisal on the fly. I was at a workshop at Duke, and they taught this, and it's Frisbee. So when you've got an RCT in front of you and you're looking at the degree of follow-up they did, so they should do at least 80% in each arm follow-up. We mentioned that earlier. They should talk about randomization. I mean, from the title, it should be clearly a randomized controlled trial, but they need to go beyond just mentioning that. Then they should have a section on intention to treat. Once that you've been randomized, you're always analyzed in that arm. And there should be some references to what they did about dropouts and so on. And particularly if there was unequal dropouts. Were both groups same at baseline, or were there biases that were affecting the outcome that they're not mentioning? And were both groups given equal care? So that's a really cool way to, if you just have a RCT popped in front of your face and you want to break it down, this is a good way to break it down. From CASP, who is the Critical Appraised Skills Program in the UK, and I recommend them a lot. They have a lot of good information. I've referred to them a lot here. They came up instead of with Frisbee with RAMBO. So RAMBO would be looking at a study recruitment. Was it randomized? Was there a clearly focused research question? Did they have inclusion and exclusion criteria? Since they're using a sample, do they have a sample frame? And was the baseline, like I said, in the Frisbee similar? How did they do allocation? Was allocation random? Was it concealed? So when they were employing people in the trial, does the study clearly say the officers doing that had no idea which arm of the trial that they were enrolling people in? Do they tell you the method of concealed allocation? Is it some kind of computerized method, or what exactly do they do? Maintenance. What do they do to reduce losses to follow-up? How do they assess differential dropout? Maybe one group, the research group, has a much greater dropout, or maybe the opposite's true. Again, do they do intention to treat analysis once randomized, always analyze? And how do they handle dropouts versus non-dropouts? Blinding. What levels of blinding do they do? Do they do single blinding, which is just the patient, double blinding, which is the provider, triple blinding, which is the data analyst? And do they describe that, not just say we did triple blinding? And finally, what kind of measurement? It should be objective. So a objective measurement would be a stroke. They had a stroke or they didn't have a stroke. Subjective measure would be pain. So RAMBO could be helpful too, to help you when you're looking at the literature, automatically your eyes gravitate towards these things. So CASP, I mentioned, the Critical Appraisal Skills Program, does have these checklists online, and I'll be willing to send a PDF version of all of them. They're free. You can find them yourself, but I'll be glad to do that to the department if anybody would be interested in looking over these or going through them. They're just checklists that you set beside the article that you're reviewing to help you to remember to critically appraise everything that should be appraised. So they have one for systematic reviews. They have one for randomized controlled trials. They have one for qualitative studies, cohort studies, case control studies, economic evaluations, diagnostic studies, and clinical prediction rules. And all those critical appraisal checklists basically do this. They ask, is the study design valid? And is it methodologically sound? What are the results? And most importantly, will the results help where I practice? Which is what all this is about and nothing more. So one way to do critical appraisal is to read the paper. I would say number two, identify the study type, because if you don't know the study type, you don't know what checklist to use, and then use the CASP checklist. So to know what study group something is, or to know what methodology critical appraisal sheet to use, you need to know a little bit about study types and methodology types. So this is a classic pyramid that puts those in a hierarchy of their clinical value. So at the top of the heap, they have systematic reviews and meta-analyses, primarily implying that these are systematic reviews and meta-analyses of randomized controlled trials, because you can do a systematic review of case studies, I suppose. And then below that is randomized controlled trials. You could draw a line below RCTs to say everything above that is an experimental study where there's a lot of control by the investigator of all the pieces. But below that, starting with cohort studies, you have observational studies, and you don't have the control. And each step downward leads to more potential biases coming in and affecting the results that you're getting. So, but still, these are not bad studies. They're great types of studies. But if you had a choice between like a case report and a well-done RCT, you need to take the RCT. So then cohort studies, case control studies, series of cases, individual cases, and then at the bottom, ideas, opinions, animal research, test tube research. That kind of relates to this pyramid, roughly. This is more of commercial products. So I'm not sure about this systems thing, but anyway, this one here, summaries, would be like Dynamed, Essentials Evidence Plus, Up to Date. Some people don't like Up to Date. They think it's too textbooky and that it doesn't list levels of evidence, and they're not transparent about how they put their sections together and other things. But that's up to you. So these are ones that have already been critically appraised up here. And that's the best way to do critical appraisal, is to find pre-critically appraised works. And then down here, just individually critically appraised articles. I don't know if Psychiatry has something like the daily poems just for the profession, where somebody sends out like a critically appraised journal article by email to subscribers on a regular basis, like the daily poems. That's an example of that happens Monday through Friday. And then finally, at the bottom of this pyramid is the same stuff that was in the other pyramid, the systematic reviews, RCTs, and so on. So that's how those methodology types fit into the current types of literature types that you have available. I mentioned bias. That's the bugaboo of finding the truth. Selection bias is when there's difference between the baseline characteristics of the groups that are compared. Detection bias, you're making a difference in how you're determining the outcomes in the groups. Attrition bias, we've mentioned difference between withdrawals in different groups within a study as it goes on. Performance bias is where you give different care to different groups. And reporting bias is a problem in the US. So if you were doing like a systematic review, or you were just wanting to find all the evidence on a topic and everything that you found was glowing or positive, that could be because US editors don't like to publish negative studies. But maybe if you got a hold of some of the same people or other people, you'd find out that were well done clinical trials that had negative results for, like, say, a drug, but they never made it to publication. So that biases, if you think you're looking at the whole picture, you might not be. So this is almost like a joke, but David Sackett, he was at Toronto, and he's dead now, but he was sort of a founder in the need to use evidence at a very intelligent level in medicine. So this was back in '79. He scanned the literature, and he came up with all these biases that he found in the literature. And I'm not going to read them all, but the all's well literature bias, the one-sided reference bias, the positive results bias, the hot stuff bias, the what's that? Popularity bias, the centripetal bias, the referral filter bias, the diagnostic access bias, the diagnostic suspicion bias, the unmasking bias, the mimicry bias, the previous opinion bias. And like I said, I won't keep going, but obsequiousness bias, apprehension bias, repeated peaks bias. Some of these names are funny. So when you actually have to find the evidence, I mean, that's traditionally what you think of as, the library resources, and certainly uses for that. I'll mention some. There is a new PubMed. PubMed is not really an evidence-based medicine tool. It's a primary tool, but I'll show you something how to kind of rig that. Of course, I mentioned Cochrane from the start, Archie Cochrane. Well, the Cochrane database is systematic reviews, and Cochrane Central, which is a repository of about 1 million randomized controlled trials we have. TRIP, we have a link to. There's a paid version and a free version. It stands for Turning Research into Practice. It's a British product, and I don't use it that much, but I mean, it searches PubMed and it searches everybody else's stuff, but I mean, it's okay. I found some good stuff there in the past. The critical appraisal, pre-critical appraisal type tools, Dynamed UpToDate, EE+. Of course, Micromedics I just put in there. It's a drug database that we have access to, which is a real Cadillac drug database. And just let you know that we do classes, and we can put most of these products on your smartphone if you so are interested. But I mentioned PubMed. So this is my PubMed screen right over here. I wish I had time to, log in and go into PubMed and show you this. But this is my front screen on the front left. And this doesn't exist unless you create it. You have to go into my NCBI and create these filters. So I have created these filters, and I brought the evidence pyramid over here. So you can see, like, systematic reviews. I've got systematic reviews, meta-analysis. I've got that. Randomized controlled trials, cohort studies, case reports, case control studies. I've thrown in cross-sectional studies. And so the qualitative people won't say that I'm a quantitative tyrant. I've got qualitative studies in here. And I definitely believe, there's a time for qualitative studies. So I've got this matched over here. I've almost got this embedded into my PubMed engine. So now when I do a search for you and I get 514, that used to overwhelm me, and I didn't know if I was giving you junk. I'd say 514 is a lot, but 26 meta-analyses are handleable. They're manageable. So are, systematic reviews that are 18. They're probably the same articles, because probably most of these articles are a meta-analysis and a systematic review of. So, so this has really turned PubMed more clinically useful to me, and for those that I serve, particularly when I'm doing a search that's a clinical search for them. And I know they just don't want stuff. They want the best evidence. Part of this right here, well, I'll show you another slide in a second, but PubMed was started in 1966 electronically. It existed in print back to the late 1800s, but and then they did go back and digitize some before 1966, about 10 years ago, selectively. But you can see the increase of medical knowledge. So over in 2020, there was it's up over 35 million, or close to 35 million total abstracted articles from peer-reviewed journals in medicine indexed in PubMed. And that's just crazy. I just did depression as a search, just a text word search, I think. And these run reverse. So last year, just on depression, there was 30,000 plus 35,000. You can see that arrow shoots up there. 35,000 plus articles, new articles indexed in PubMed just on depression. Interestingly enough, again, this one runs the towards the left. The other one ran, the other chart ran to the right. But you can see PubMed started in 66. So what's this long tail? Well, that's what I asked myself. And I actually looked up this 1789 article, and it was an article that dealt with depression in the sense that somebody got hit in the head with a hammer and it left a depression in their head. And that got me curious. I'd never seen a tail like this. I knew they indexed some older stuff, but very little. So I had to find one that dealt with our topic here. And I found one from 1816. Case of melancholia from a material cause in the brain, terminating in effusion of blood there, and apoplexy with the appearances on dissection. James Foy, surgeon in His Majesty's Naval Service. So there you go. Again, point of care tools like Dynamed, EE+, TRIP, they do the critical appraisal for you, but you still need to know what it means. Information overload is part of the management of all this. So I did this little chart here where there's 84 new articles on depression coming out every day. There's 4,437 articles coming out in PubMed every day, and there's 88 new systematic reviews. And when you compare and contrast that to this, this study found out that physicians' knowledge deteriorates over time. They, in this study, did a measurement of how far away it had been from graduation for physicians from their residency program. And the further away they were from that, the worse they can form. I think they were measuring something that there was an agreed gold standard on. I think it was hypertension. So this is getting bigger and this is getting worse. Not good. So let me encourage you to use me, to use my colleagues. When you do lab work, use a medical technologist, or when you need lab work. When you need an x-ray, use a radiographic technician. So when you need information services, certainly ask librarians for their help. I just threw this in there. It doesn't really fit that well, but basically what you want to do is stuff that reduces your work as far as your critical appraisal life. If it's going to take too much work, no matter how relevant and valid it is, it's going to be useless to you. Again, mention Cochrane, the two databases we have. I kind of wanted to mention Archie at the end, just like at the start. I think that in conclusion that we ought to have a bird on campus. That stands for Biostatistical Epidemiological and Research Design Center for the whole college, for students, for residents, for faculty. And you could go there and they could help you to design your research methodology. They could help you with the biostatistical tests you need to use. They would help you with how to analyze those biostatistical results. They would show you how to prepare a document, how to submit it to a journal, and so on. I really see people groping around all the time because I run into them that need help in one of these many areas. And I just think that would be a smart thing. I want to thank you for this opportunity. I consider it an honor. The department lets me work with the clerks in psychiatry, do PubMed training for them. I do that with Dr. Bird. I've been privileged to do some classes with the residents and participate in their journal club and be here today. And I think that's a true honor. And finally, all this is for ways for you to develop skills and to use the work of others so that critical appraisal in your practice.
Bro, look who's even here. It's just nice.
Is something that is second nature to you. And when you do become an expert in critical appraisal, then you're your own data analyzer. You're not dependent on somebody else. And if you're your own data analyzer, then you're a Yoda. Thank you.
Thank you, Dr. Wallace. If anyone had any questions, they could type it in the chat or they can say it now.
Did I do okay on the time?
Yeah.
Good.
Mhm.
Yeah, that's perfect. That way you have about 10 minutes for questions. If anyone has questions, they can go ahead and ask those.
I think the next journal club is March the 2nd, I believe. So I'll see a bunch of you there.
Yes. Well, thank you so much, Dr. Wallace. Appreciate your presentation and it's really
Thank
informative.
you. It's a real honor and I really appreciate it. And, you know, I'm sincere. If I can be of any help to anybody, please contact me. So thank you all.